So, of course, they know this, and they know that they might there might be, at the very least, sort of a public relations problem. So, what if they said they're going to do with all this net income, with all this profit they're experiencing, because they're taking in roughly the same amount of premiums, but don't have the same expenses, at least in Q2?
I mean, right now they're reporting it as income. There are a couple of options for the health plans that they can do, and some of them have been taking advantage of those options. So the thing that many of them have been doing, and I believe that United and Anthem have done this, is that they have been advancing money, which basically means that we will provide you the cash that we expect you to spend so that you can meet your payroll, PCP office of 3 doctors, or rural hospital that's suffering. We'll give you basically your Q3 money in Q2, or we will take the lag that we normally have. If we normally lag your payment by 6 weeks, we'll give it to you up front so you get flush with cash and you can meet your payroll. But that's not new funds. In other words, that's money that they're just fronting you. That's an advance on your salary, not a raise. What Medicare has done has said what they have potentially said they would do is that they were just going to pay based on what the revenue was last year and just pay that this year. So there have been discussions of doing that, because like all the elective for surgeries procedures went away. And so, but they were there in Q19. So the way that a hospital or a provider group stays afloat is having that revenue from last year. As long as it's the same, they should be okay in 2020, just as they were in 2019. So if you were to provide the same revenue in 2020 as you did in 2019, then these providers should be okay. So if you just front that money and provide the money from last year, that would be one solution to this issue.
Now, these large profits and net income are sort of contemplated in the ACA, and there's a MLR limit of 85%, right? So my understanding is that they would be forced by the MLR rules to, in some sense, give some of this money back, because they can't have an MLR under 85%, and therefore they're compelled to give some, as I say, give some of this money back. I believe to the people who are paying the premiums, employers and employees. So, isn't that sort of the policy fix to this? Isn't it already built into the ACA?
Sort of. So that is definitely, everything you said is exactly right. However, the way that MLR is calculated now is on a 3-year rolling average. So what the MLR does is that it prevents a health plan for each plan from having an MLR of, let's say, 50% for multiple years. But if they have one banner year, which is what it looks like they're going to have, it will get averaged in with the prior year and the next year and so maybe it will go below, but basically, they will still reap the benefits of having this year as a banner year, right? Unless both last year they go below the 80% or 85%. It depends on which market, individual, small group. And then next year do the same thing.
So we might have to wait and see about how the MLR acts on these companies till next year, because it's a rolling average over.
We will definitely, and it'll be at least 2 years. So like the other issue is that by the time the consumers receive any benefit from this, it will be at least 2 or 3 years out, right? Because we've got to wait for the 3-year rolling average, and then it needs to get calculated by CMS, and then you need to get your check back. It takes a good long time.
Yeah, and especially these days, long waits. The world's changing so fast. I mean, the idea of waiting for a rebate, a return 5 years from now or 4 years from now, whatever. So, do you have any some different policy prescriptions about what should happen here, and could, in light of their the amount of revenue that they're realizing and the decreased expenditures, couldn't they just lower premiums?
Sure. So lowering premiums would be one thing that would give that benefit back to the consumers. And in fact, my car insurance did that. They said, you're not driving as much, and therefore, and nobody is driving as much. Therefore, there are fewer accidents. Here is a rebate. And I would imagine essentially ASO businesses doing that. However, the companies are probably retaining the rebates rather than and the companies are the primary payers, but
Yeah.
I would imagine that is not funneling down to an individual who's getting a check from, their large company. So rebates would be one thing to do. However, we have all of these providers that are in financial distress over this lower utilization. And it seems to me one of the, best options would be to make sure that they're fully funded. They're the ones that are taking the personal risk and seeing COVID patients and not doing right. And they're getting redeployed from being a cardiologist or an endocrinologist and seeing COVID patients and taking personal risk, and the nurses as well, they're all doing this. So to see them also taking a pay cut as they have to go through, both personal risk and doing something different than they were normally doing, and then have financial repercussions to it through no fault of their own, that is very hard to see. So hopefully the providers will be the plans will help make the providers whole.
But isn't there a problem that there's a tale of two cities within the providers, and that some of the well-to-do hospitals have, with deep reserves are doing okay, and some of the hospitals in poorer parts of cities, in parts of cities that serve Black Americans, are struggling. So if it sort of goes to providers, are we sure it's going to go to the deserving providers, or the providers that might really have an effect on the people who are most vulnerable in this pandemic?
Yeah, that would definitely be a concern. So, for example, HCA is like the largest for-profit healthcare, conglomerate or corporation in the United States, and their profitability went up. And they did some furloughs, and there were a whole bunch of cuts there, but their profitability definitely went up relative to a quarter a year ago. And some of the other for-profit institutions did as well. So yes, it absolutely depends on the organization.
Now, there's a part of the title of your paper that mentions plans requesting higher rates, even as they enjoy these large margins. So could you discuss that? Which plans and in which markets? Are we talking the individual market here? Are we already seeing maneuver around the group market? What's going on?
So that's a great question. That was a really a mixed bag. And I found this fascinating because the way that bids get done is that, it's a secret. In other words, the plans, maybe they talk to each other, and the actuaries all sort of know each other, but they don't really talk to each other. And so the bid that you provide to the Department of Insurance, or in New York, the DFS, Department of Financial Services, or whoever it is in your state, they are secret plan by plan. And so you submit them, and the examples that I'm using are basically from the exchange plans, but they're probably representative of all of the individual and small group market plans. So for example, in New York, Oscar and Fidelis both applied a 15 to 20% increase to their rates, whereas all of the other plans in the market had a 1 or 2% or a 0% increase, a very, very big difference. All of them said COVID was responsible for it. And now this isn't unreasonable because nobody really knows what COVID is going to do. Although we do have a sense of what COVID did in the first half of the year in many of these institutions, many of these organizations, which is that, it led to a decline in elective procedures. And while there may be some pent up demand that comes back, a lot of that demand just washes away.
So, and just to be clear, they can make these premium requests, but state officials still have to agree to them. So Oscar and Fidelis may be there with the tin cup, so to speak, but it doesn't necessarily mean they're going to get those rate increases.
Absolutely. And I would imagine that the state regulators are looking at, all of the evidence as they decide to set rates, and it may vary by plan, right? In other words, you may have a population that is particularly susceptible to COVID or severe COVID or something like that, but they're going to be looking at all of the plans at once as they make their decisions on rates.